Hello, everyone. My name is Frank Rahaghi. I am a professor of medicine at Cleveland Clinic and the chairman of Department of Pulmonary and Critical Care, the director of Pulmonary Hypertension Clinic here in South Florida. And today I'm going to talk about pH therapies in the United States today and tomorrow. So, as you know, there is 5 classifications of pulmonary hypertension, and it's really interesting. If it were up to me and I could rename this disease right now, I would not call it pulmonary hypertension. I would call it pulmonary vascular restriction, because most of the interventions that we have that brings us together is in basically taking away that restriction. The other problem is it creates confusion because a lot of patients who don't have any pulmonary vascular restriction or resistance are actually probably have cardiac issues, and it gets all mixed up because the word pulmonary is in there, and yet there's no involvement of the lungs. How can that be? And yet 70 to 80% of patients with the word pulmonary hypertension on their echoes actually have left-sided disease. Now, they may have some restriction mixed with their pulmonary hypertension that comes from the left side of the heart. So category 1 are people with pure pulmonary vascular restriction with no lung damage, no clots, and no heart damage. And these people are idiopathic, heritable, drug-induced, and connective tissue disease related for the most part. Then we have the left-sided patients, group 2, which have either backup of the heart from working poorly, either because of low ejection fraction or preserved ejection fraction, which is called diastolic dysfunction, that nobody knows how to treat well, valvular heart disease, congenital stuff, etc., and heart failure. And then you have lung disease patients who have pulmonary vascular restriction, but then it's mixed with a lung disease. Big categories are COPD, interstitial lung disease, and some hypoventilation. And treating these people was not easy because they're at risk of having low oxygen by treating their pulmonary hypertension. So it's not easy to treat these patients. And then we have the patients who have clots in their lung, chronic thromboembolic pulmonary hypertension. And interestingly, chronic does not refer to thromboembolic. It actually refers to pulmonary hypertension. This too should have been chronic pulmonary hypertension of thromboembolism, because there's people that develop lots of people develop pulmonary hypertension immediately after one attack of thromboembolism, but then only 3% actually end up having chronic pulmonary hypertension from thromboembolism. The name implies to a lot of people that you should have repeated clots. That is not true. And then finally, you have an area where you put in all the things you don't know what to do with. Hematologic disorders, sarcoidosis in particular is in this area of group 5, which is a non-cohesive random grouping of things that we didn't know what to do with. So the specific therapies that are approved in the US, basically 3 broad categories: the endothelin receptor antagonists, ambrisentan, bosentan, macitentan, PD5s, sildenafil and tadalafil, soluble guanylyl cyclase stimulators, which is riociguat, that works a little bit upstream from PD5 inhibitors. Then we have the whole category of prostacyclin and prostacyclin analogs and receptor antagonists. The main receptor that does the business of improvement in pulmonary hypertension with regards to prostacyclin is an IP receptor, and that's what selexipag targets. The other prostacyclin analog, treprostinil, iloprost, epoprostenol, they help that receptor, but also other receptors, different ones. Iloprost is only inhaled in the US. I know it's being used extensively as IV. We have Flolan, epoprostenol, and Velletri, another formulation of it. They're now both, to a certain degree, room stable, Velletri more than Flolan. And treprostinil, which can be used in all ways with oral, inhaled, IV, and sub-Q. And I believe most of these are available to you, except for treprostinil inhaled, which is a pity because it's sort of one of the better ways of using treprostinil, and there's no new indications for it. But I think they're making ways into Europe as well. So in the past, the way we used to think about therapy is by functional class. You were functional class 2, you got a certain kind of therapy. Functional class 3, different kind of therapy. Functional class 4, yet a different one. And then we realized functional class is too limiting. Sometimes people have okay functional class, but they're near death because of other issues, or they have other problems. So we got smart, and just like liver doctors and other doctors use a composite score to give you a number that defines how bad your situation is, we also came up with a variety of ways, and by we I mean the pulmonary hypertension research world, to basically quantify a patient at that moment. And this is risk scoring. There's multiple different ways of doing it. My guess is Europeans are using the European ways, and they're very good. And in America, we're mostly using our sort of homegrown Reveal 2.0 light. And all of these risk assessments essentially try to comprehensively look at a patient. And what is a comprehensive look? What are your biochemical markers of heart failure? How are you doing clinically? How are you doing with exercise? How's your echo doing? And if there is hemodynamics, how are they doing? And then by putting together some of these yellow boxes, you come up with a score that then you can follow the patient with, which is much better than looking at them and just saying, oh, you're sick and you're not. So the one we use now mostly is Reveal Light 2.0, which has 6 variables. Whether your kidney is bad, which has to do with end organ damage, your functional class, your vital signs. If your heartbeat is more than 92, that's bad. If your blood pressure is less than 110, that's bad. If your 6-minute walk test is more than 440, that's good. You lose a point. And if you are less than 165, that's bad. You get a point. Same with BNP, less than 50, you lose 2 points. That's really good. And BNP over 180, you gain a point. You add up these points, you add 6. And if your number is over 8, your mortality is up to 15%. If your number is intermediate, 6 to 7, 7% range of mortality in 1 year. And if you're low, 1 to 5, then it's less than 2.5% mortality. And remember, this is just mortality, but there were so many patients that were not being treated because they looked good or their functional class was okay, but they had other issues that pointed to a worse scenario. And so the new wave in America, and I'm sure everywhere, is the use of these risk assessments. So as patients, I think you now can ask your doctor, what is my risk score and where am I going? Because that is now driving treatment. In this last New England Journal article by my friend, Dr. Hassoun, basically suggest, and reflecting other bodies, the use of risk in terms of deciding what the patients go on. If you're a high risk, patient needs to be lung transplant or definitely an IV sub-Q, some sort of parenteral prostaglandin agent. If you're low and intermediary, you can consider monotherapy or dual therapy, but preferentially dual therapy, because we now have proof that it's better than monotherapy. And then you follow the patient, including with risk scores. And if they become low risk, you could consider staying there. And if not, escalate. And eventually, if escalation gets you to the end of the road, or maybe a little bit closer before the end of the road, you should consider transplant. Now, that's all good, but does that mean that if the patient's low risk, you're supposed to be okay with that? So it turns out that, for instance, Uptravi or Selexipag, they looked at their low-risk patients, and the low-risk patients who basically had good numbers, they too were actually having a 42% reduction in bad outcomes that included morbidity and mortality. And so why not then treat low-risk people by adding Uptravi? So what does that mean? That means essentially that low-risk status is not even good enough. So if you start on dual therapy, and even if you're low risk, you have to end up on one more drug, does that mean should everyone be on triple therapy? I actually submit to you, yes. Why are we beating around the bush for this? Everybody should be on triple therapy, or at least that's what I think. Now, we make a big deal about these grouping of pulmonary hypertension, your group 1, your group 2, your group 3. But really, pulmonary hypertension is a disease of PVR, first and foremost, or should be a disease of PVR, and our solutions are PVR solutions. So if you look at it pathophysiologically, it's not that the patients with group 2, 3, or 4 that have pulmonary vascular restriction and elevated PVR, pulmonary vascular resistance, have different lesions. Their lesions look the same, essentially, maybe slightly different. There's more plexiform lesions in group 1, but it's been seen in others as well. So it's not like they're fundamentally a different looking pulmonary hypertension with different looking patterns. And in fact, over the years, in group 4, we got riociguat approved for post-pulmonary thromboendarterectomy patients that have still pulmonary hypertension, or people who don't want to get operated or are not operable, which showed benefit and is actually approved in the US. Most lately, and this is why I hope Tyvaso gets to you quickly, the patients with interstitial lung disease, they were found to be better. And not only their pulmonary hypertension got better, but their lung disease seemed to have also gotten better. And so Tyvaso was approved in group 3, patients with ILD, not COPD yet, they're doing the trial now. But maybe it doesn't really matter. You just have to be careful and use the right drug in the right groups. And sarcoidosis, which is group 5, even though riociguat did not have good results in patients with interstitial lung disease, in patients with sarcoid interstitial lung disease or sarcoid, and I was part of this group with Dr. Boffman, we put 8 patients on riociguat, and there was tremendously good response, albeit in a small subgroup. So we're making headway into the other groups, and maybe it's time to rethink them. So then let's talk about meds. Now that we're going to have so many different meds, is there a different way of approaching medication? Well, right now we have 3 pathways: nitric oxide pathway, prostacyclin pathway, and endothelin pathway. And in each, we have a set of drugs. And right now, we're starting with dual therapy with endothelin and nitric oxide, most likely ambrisentan and tadalafil, though people use Massey and riociguat as well. And then maybe if the patient's not fully well, and remember I just told you earlier, maybe they should go on it anyways, use selexipag, or with the replace trial, if they're not doing well and they're on sildenafil and tadalafil, to switch to riociguat, which tends to make them better. So this was sort of our MO. But actually, if you really think about it, if we're going to have many, many medications, and this started with Ibn al-Nafis in the Muslim caliphates, who described pulmonary circulation, and then William Harvey rediscovered it during the Renaissance. And eventually, Werner Frostman was an intern in urology who basically inserted a catheter. I hope he washed it before in his vein, and went and took a picture of himself with an X-ray and got fired, but eventually got the Nobel Prize for starting this field. And eventually it's been an amazing set of wins with the approval of bosentan, treprostinil, iloprost, inhaled prostacyclins, sildenafil, ambrisentan, tadalafil, macitentan, riociguat, selexipag, et cetera, et cetera. So really an embarrassment of riches, and new potential agents coming up. There's a lecture on potential agents, so I'm not going to talk about them in terms of actual chemical agents, pharmaceutical agents, but we'll talk about some stuff. So that simple plan ended up being this really complex pathophysiological landmark that is ready for interventions in every blue triangle, rectangle that you see. Some of these drugs, by the way, they already were started and were not found to be helpful, like bardaloxone was already found not to be helpful, really. And so there is so much now. What are we going to do after this? Well, maybe we should look at what they do and say, okay, so far we put drugs in a category of vasodilatory. Clearly, sildenafil, tadalafil are in that category. And I submit to you, they're probably going to be added to any cocktail because they're safety and ease of use. Then we get to the anti-proliferative set, which includes ambrisentan, macitentan, but also treprostinil and iloprost. And lastly, there is this category now that is emerging that's called disease modifying. So they're saying we are more than vasodilatory, we are more than anti-proliferative, we are all. And so that led me to the question, what is a disease modifying agent? Well, the people that use it the most are rheumatologists and most recently Alzheimer doctors, which in this definition by EMA, for regulatory purposes, a disease-modifying effect will be considered when a pharmacologic treatment delays the underlying pathological or pathophysiological disease process, and it should be accompanied by improvement in signs and symptoms. So this is something that not only changes something fundamentally, but downstream affects all, if not most, if not all, of the manifestations of the disease. So you shouldn't just say it, you should actually also do it. Which brings me to this. So the worst kind of therapy, but actually not unimportant, is symptom relief agents. When you're in pain, relieving your pain so you don't feel it is important. But then also is important what gave you the pain. And this is where we are at. We're at the disease mollifying agents. We have pathways that contribute to pulmonary hypertension, prostacyclin pathway, IP pathway, ERA pathway, and they modify symptoms, multiple symptoms at times, but in their individuality have not been fully capable of conquering the disease. And so what is disease modifying, and this is on the other end, where they address a key pathological abnormality that is so upstream and so important that it results in the beneficial effects in secondary pathways, at least two or more, multiple ones. So then they in themselves result, or directly these pathological manifestation abnormalities being addressed results in improvement of symptoms. And so we are now getting enough into the woods that pharma companies are suggesting that their drugs are disease modifying. And it very well may be true. Drugs that are being studied now, such as sotatercept, inhaled imatinib, seralutinib, rodatristat, which has to do with serotonin. These are drugs that seem to affect large chains of downstream effects. But actually, didn't prostacyclins do that? So maybe prostacyclins should have called themselves disease-modifying agent too, because I'm sure you know patients, maybe you are one of the patients who is on a prostacyclin for 20 years and is alive and running around and feeling great. So maybe we should not necessarily suggest that prostacyclins are not disease-modifying. This is an interesting area that is going to be an interesting battleground in the future in America. Now, actually everywhere. Now, some of our old friends are coming back with a new look. They get a facelift. For instance, Tyvaso here in America was available in a giant nebulizer. Now it's going to be a tiny inhaler. The pumps that were used for Remodulin, we now have this tiny Remunity pump. So discreet and so user-friendly. And then macitentan, hey, we gave you 10 milligrams a day. What's 10 milligrams when you can do 75? Anyway, so high dose macitentan. And then imatinib in pill form, Gleevec, did great things, but because of side effects, adverse effects, serious ones, in a few patients, might I add, it was not submitted for approval anywhere. But people are excited about inhaled imatinib. they're hoping that the inhaled formulation will get around the serious adverse effects. So some old friends are coming back with better clothes and a facelift and hoping to help us improve patients' life. So the other direction we're going is towards precision or personalized medicine. By the way, they mean the same thing. People who deal with these categorizations decided that personalized meant that it's almost like a bespoke suit, that a specific mixture of drugs is going to be, like a specific drug is going to be designed for them, as opposed to precision, which means use what we have more precisely on the patient by understanding them better. So personalized is out, precision is in, but they mean the same thing. And what that means is, even with the mighty imatinib, which we think of as maybe a disease-modifying agent, there were people that didn't respond. Granted, if you look at the blue bars, more people with blue bars improved, if you look, and more people with placebo got worse. But still some people with imatinib got worse. Now, it could be their disease was so bad, or maybe they were non-responders. We just don't know. And there are some things you can measure, but we're not ready for any of this. We're not ready for any of these markers that we can measure to give us a clue on what to use. We have not found people that are better off using ERAs, or people who are better off using riociguat, or people who are better off using iloprost versus epoprostenol. This is not ready. And we need to get there, though. And imaging, actually, and my brother, who apparently also has a talk in this forum, is one of the people who is dealing with imaging as a way to try to phenotype patients. For instance, we have on top here PAH versus exercise PAH versus control, and you can almost see the difference in them, and there is a difference. And so maybe this will help us phenotype our patients, so you will know what kind of even idiopathic person you are and which drug specifically is applicable to you. But we need a lot of data, and we need a lot of processing. So in the US, the PVDomics effort is trying to gather a lot of data from the patient, and using clinical data, genome, transcriptions, proteins, and metabolic function of a patient, come up with profiles that we can recognize in our patients, and then attach them to a specific drug, so that after running the patient through a series of tests, not only you can say that they have pulmonary hypertension, not only you know how bad it is, not only you know how many drugs to use, but you also know which drugs to use of a mixture of the drugs that will be available. So this is happening not soon enough. So in the back, we said that we have mollifying agents, agents that address one pathway, and now we have agents that address a lot of pathways. Why not cover them all? This is a condition that is not cured. We're doing better, but not fantastic. I still lose a lot of patients. I'm sure you lose a lot of friends. So why not go big right away? This study, which is obviously not randomized, but a sort of a registry analysis of patients in France. And I call it Raising Lazarus because this is one of the most impressive results anywhere in the field of pulmonary hypertension. People's 6-minute walk test went from 227 to 514. That's an increase of more than like 290 meters. That's amazing. And why wouldn't it be? You have a disease that not one thing works at, and it seems like if you attack it from multiple dimensions right away and up front, you'll be able to make a bigger difference in people's lives. And yeah, we have improved 5-year mortality from 70% to 30%, meaning 70% of people are alive. but still 30% of patients were losing them. We shouldn't rely on low risk to stay on dual therapy. We should really actually go to triple therapy. And in fact, we should go straight to triple therapy. There's multiple trials showing that 3 is better than 2. And why not start right away? Why wait? This is a disease where pretty much people get worse. And every single time you intervened early, except one trial, the Triton trial, we've managed to improve people's lives. So think about cancer. Would we wait till the cancer metastasizes before really treat it maximally? And unfortunately, the way things have developed is not because somebody thought this out. It happened because we rely on industry to provide trials, but they don't necessarily provide the ultimate trial. They provide trials in a way that's commercially sensible because they have to get their drugs approved, et cetera, et cetera. But if you look elsewhere in the worlds of, for instance, cancer, HIV, or tuberculosis, you're dealing with diseases that are hard to handle. You can see that people in medicine typically use 4, forget 3. 4 is the magic number. MOP in cancers of hematologic cancers, quad drug for HIV, 4 drug therapy for TB. Anytime we deal with a deadly disease and we have 4 pathways to hit it, we hit it with the 4 pathways that we have with better outcomes. Why would this be any different? So the other push is towards supportive interventions. Yes, drugs are good, but we need to provide other support for our patients because, well, as you know, some people don't take their drugs correctly, et cetera, et cetera. So we thought, okay, where's the evidence? Me as a center director, what can I do for my patients that will actually help them do better? And so obviously pulmonary hypertension numbers are not big enough to run trials like this, but you know who has those numbers is heart failure doctors with a regular heart failure. So we sifted through the literature of heart failure, trying to see what things worked for heart failure patients. It turns out that case management, which means somebody being in charge of you, that calls you, makes sure you're okay, and pushes your agenda and makes sure you have follow-up visits and taken care of, actually helps you live longer and better. In other disease states, we see this all the time. In Alpha 1, there's a volunteer organization that alphas call other alphas to make them do the right thing. I guess more responsible alphas call the other alphas. And that also resulted in improved mortality combined with correct therapy. So multidisciplinary interventions, which involve multiple physicians and or multiple specialties and multiple caregivers like case managers and physical therapists and nutritionists, helped. Telemonitoring is controversial a little bit. Some helped, some didn't help. And a meta-analysis suggests that if you have something that monitors your health and either warns you or warns your care provider, that it could be helpful. And calling people, even with somebody who's not a major healthcare provider, could be helpful if there's a structured phone interview that basically asks the right questions and flags people that need help and guides them. All of these things have helped. So we're talking about expensive drugs, rare drugs, difficult diseases to take, but there's a lot of ground to cover just by doing better and managing heart failure, and managing diet, managing fluids, which are not done adequately in America. And I'm sure that everybody could use an improvement. So we talked about interventions, we talked about new approaches. How about things that are not drugs? Well, gene therapy is coming. Gene therapy is coming, and I actually myself was doing research in adeno-associated viruses where you use like a cold virus to basically stick the gene that you're missing. So what's the problem? Well, even though we found some genes that are effective in pulmonary hypertension, we have not found one gene to do this. And that's even before figuring out how to actually dependably get that gene into the patient. But this CRISPR-Cas technology, this gene editing technology, once we figure out what is the genetic background of pulmonary hypertension in every person, may be really helpful but I'm afraid we may have to intervene in multiple genes. So this is not ready for prime time, but it's happening in the background. Now, this really works if your pulmonary hypertension comes from you and your family and your grandma and everybody having pulmonary hypertension from that one gene. So familial people will benefit from this first. Pulmonary artery denervation, it turns out that your sympathetic nervous system tends to constrict your arteries unreasonably in patients with pulmonary hypertension, and burning it helps. And so when they do this, the pulmonary arteries pulmonary pressures go down, the pulmonary vascular resistance goes down, and the 6-minute walk test actually goes up. And this is why not? This is a one-time deal, and I'm surprised that it hasn't caught on in other places, but maybe because it's different in different people's hands, and it needs to be maybe a little bit more standardized. And now, for the best news ever, which I'm sure you're aware of it, brand new lungs. Lung biotechnology, actually recently, one of their divisions scored that transplanted heart that was voided of all antigens, and basically was pig heart that was voided of all antigens and basically was transplanted into the patient. Now, the same thing they're using by basically using the a lung of a pig and basically washing the cells out of it and putting the human stem cells on it and basically make a lung for you that you will not reject. Also, they're 3D printing a scaffolding of a lung and then pouring patients' stem cells on it and resulting in a creation of essentially a lung designed for you. It's a human printed hybrid lung. Now, how exciting is that? And it's not years from now. The U lobe, maybe few years. The U lung also maybe like a 10-year horizon. We're not talking about forever. Martin Rothblatt, who is the CEO of Lung and United Therapeutics, he's already developing drones to fly these lungs around to places that need it. So within our lifetime, folks, I really hope so. So a lot of excitement. So things are good, but really between you and me, they're not good enough. Still have very high 5-year mortality. Stay paid, many die without getting all the drugs, especially prostacyclin. Still a lack of urgency, at least in the United States, by physicians and maybe by patients who are taking it kindly, maybe. I'm just saying HIV patients are now not cured, but their health is restored. When their pandemic was killing them, they really acted up and asked for a cure. So I don't know why in PAH we're not more vocal about asking for a cure and really expecting normalcy and health from our physicians, from us, from the world, from the authorities. Yeah, better is okay, but I suggest a modified version of the Brexit mantra that worked for the Brexiteers, which is, let's get our health back. So I suggest this motto: let's not be happy with okay. Let's do more. Let's find more upstream disease-modifying agents. Let's use them in conjunction with the drugs we have. Let's try to get people better right away. Induction therapy. And let's use everything at our disposal to make patients better. Thank you very much for your attention.
And we are very lucky and fortunate to have a well-known PH doctor from America with us. And he ran an excellent presentation. And there's been a lot of comment on that. People really enjoyed your presentation. And we have a lot of questions. I don't know, I've sent you the questions. I don't know if you had a chance to look at them, but I made a little presentation so we can see them here on the screen. Maybe you can just give a short introduction to yourself.
Yeah, my name is Frank Rahaghi. I'm the chairman of pulmonary department at Cleveland Clinic in Florida, and I also run the pulmonary hypertension clinic and actually the advanced lung disease clinic. So I'm active in the fields of pulmonary hypertension, sarcoidosis, scleroderma, ILD, and alpha-1. So yesterday was a good rare disease day for me. Yeah, and I attended UCSD for a short period as an observer, and that's sort of what got me interested into pulmonary hypertension. And when I went to South Florida, there was a great need for a pulmonary hypertension center. So about 20 years ago, we started it, and now we have 3 physicians and 1 nurse practitioner, 2 nurses, 3 research coordinators, and at 700 active patients under therapy. And so I've, for better or for worse, I had a lot of experience.
And you know Gary quite well, I think.
Who doesn't know Gary is the question. Well, I happen to know Gary and really like him. I happen to met his family and his lovely daughter. And so everybody in PHAE Europe is so dedicated and committed to the field and very effective in what you do. So I salute you and Gary and your whole group.
Well, thank you. And thank you again for taking your time. Why is it called Cleveland Clinic when Cleveland is in Ohio?
It's a brand. So they called themselves Cleveland Clinic, and then they realized that there is more to the world than Cleveland. So when they expanded, they just kept the name.
Okay. Because I went to school in Columbus, Ohio. So I know all about Cleveland. Okay, so we just get started on the questions. As I said, we have pretty many of them. Your table shows IV sildenafil in addition to oral. When is sildenafil treated with IV?
It's available in the US, and sometimes it's used in patients with post-cardiac disease. So it's not really used for treatment of pulmonary hypertension, but it's available. We haven't really incorporated it into our therapy, but let's say a patient is admitted and cannot take PO medication, you could conceivably use that medication. So it's not for outpatient use, but it does exist.
Okay. I just want to remind our audience that if you have any follow-up questions, you can write it in the chat message. We lost your photo now. Oh, there you are. Okay. Would you say there is a difference in treatment of PAH in Europe and the US? Don't you both follow the guidelines?
So I'm okay. So first, let's start by the fact that I have not been sitting with a PH expert in Europe and comparing notes on who does what. But I can tell you just mechanistically, the FDA and the European agencies have approved different medications. So right there, our practices start diverging. In certain countries, iloprost IV is available and commonly used, and here in the US, it's just not available. So certain practice divergences occur in terms of availability. Other practice divergences occur in the sense that in Europe, I want to say the care of PH is much more centralized, and I dare say, therefore, better, because the majority of patients are getting their medication through a center which typically is staffed and headed by experienced and dedicated physicians. That is not the case in the United States. I would say at least 60% of medications are prescribed by people that have little to no experience with pulmonary hypertension. So there's a lot of logistical differences, but it's not like necessarily the physicians, the experts in the US and the experts in Europe diverge in the philosophy of treatment. And certainly when they get together, they're in solid agreement into the direction of things and how to do things. So I would say yes and no.
Okay, yeah, because these guidelines that are developed every, is it 5 years? I guess you follow them all over the world.
Yep.
You mentioned that phenotyping of patients in order to prescribing precision medication is not available yet. Should one therefore instead try different types of PH medication, perform subsequent right heart cath or 6-minute walks in order to find out which drug that fit the best when initially diagnosed?
Yeah, that's a very smart question. Indeed, that's one way to find out what drugs work best. The problem with that is historically it has been so hard to obtain a drug. And since the disease is progressive, typically, it's really hard to say whether something is ineffective completely because, well, how do you know if things wouldn't have been worse if this drug was not on board? Now, you could, and in the presentation, I did suggest that maybe we should not just expect decrease in worsening, but demand a lot more. And in that context, a rapid switch of medication, depending on your expectations, may be the way to go. And in fact, if you look at one of the recent trials with riociguat, replace, it did basically say you have a patient who is on
PDE5,
sildenafils and on PD5 inhibitors, and they're not at goal. If you actually switch them to riociguat, they get better, and sort of they actually put clinical improvement as a goal, and they achieved it. And so, yes, that may be a strategy. The reason why it hasn't happened is the two reasons I told you. One, it's so hard to do that switch one after the other, and B, we have not convinced ourselves yet that switching, finding the perfect pathway for you and then switching to adding another drug and then finding a different perfect pathway and adding a drug is better than just throwing a whole bunch of meds at you and hoping one of them would work, because that's the other solution, which actually so far I think I'm a proponent of, is if you cover all the pathways, then you're likely to at least cover 1 to 2 pathways that work for the patient. So it's not an untrue strategy. It's just unpractical, and maybe we just have not had the guts to do it.
But on the other hand, if you have patients that are stable and doing well year after year, then one, I guess, could assume that the drug they take is efficient or good for them.
That is a fair assumption.
Yeah.
You cannot argue with success.
Another question. You suggest triple initial therapy to all. Does that mean that all should be on IV medication from day one, or will selexipag do?
Oh God! So the Triton study basically, unfortunately, did not give great results for upfront selexipag therapy. I actually think that it was partly because of the design, and I am in favor of an upfront triple therapy. There's more evidence at this point for upfront triple therapy that involves an IV medication, and the reason for that is the concept of induction therapy. The whole point about it is basically to throw as hard a punch as you can right off the bat. So if you're committed to doing 3 drugs, perhaps IV should be one of them. Although I don't think the selexipag triple upfront is a bad thing. But theoretically, and at the level I was talking, I think it's better to go all the way and then back off.
But then I guess you have the difficulties of convincing a patient to start with IV medication from day one.
Yeah, that's really funny, because why do I have this problem? I have friends who get cancer And when they get cancer, yeah, my life is sad. When they get cancer, they are ready to do anything. They take medications that make them throw up, and they're hot. These medications are a lot less effective than some of our pulmonary hypertension medication. So I'm actually wondering, why is it that cancer doctors can convince their patients to do anything, and in fact do induction therapy, but neither us nor our patients are willing to do that? I think we're all making a mistake. I think we should learn from the oncologist. Now, it may have something to do with the fact that at least oncologists in the United States have an incentive to sell the chemotherapy agents. Pulmonary hypertension doctors don't typically, so we don't push it very hard. And there is no movie called Love Story where the lovely girl dies of cancer. And so there is not this lore and commercial success pushing the world of oncology for us. So I actually don't know why it's hard to convince people not to die, I have to say.
That's a good point. What suggestions would you have for patients that are fortunate enough to live in a country with limited or no access to medication?
I have no good answer for that, unfortunately. I wish the world was a better place. I don't know. I can tell you, my mother moved us from Iran to United States partly because she wanted our father to get a heart transplant, and he did get a heart transplant. I'm not suggesting everybody move to different countries or United States, but I'm saying that unfortunately, people just do all sorts of things to get around that. And there is no systematic way of doing it until the world as a whole decides to be a better place, which, by the way, there's mixed messages these days about that.
Yeah.
I don't have an answer to that question.
No, this is really difficult, and it's difficult for us as patients when we meet other patients from countries where they have problems. And this is one of the reasons why it's so important for us to help and support and maybe get the legislation changed in these countries. And I remember one patient who unfortunately is not with us anymore. She said it was like being invited to a dinner table and see this beautiful table with all this food and not being able to eat. So, you know that there is a drug out there, but you're not allowed to get it.
But, I have to say, and I mentioned the HIV people once, they managed to do it. Somehow in Africa, we are donating medications en masse. And believe it or not, George W. Bush gets credit for it. An unsung hero of HIV in Africa. So there is precedence for developing countries allowing lesser fortunate countries to have drugs for free. And I say, like, HIV field, and maybe, they have a critical mass, the numbers are bigger, and therefore it was easier for them to attract attention. But there are models for this.
I've heard that if one performs pulmonary artery denervation, one will not be eligible for future lung transplant. Is this true? And if so, should one not avoid this procedure?
I really don't know. I think that because of the scarring that occurs, it may cause complications afterwards in transplant. But we're not a transplant center, so I'm not sure about this technical question.
New lungs with your own stem cells sounds exciting, but will not the risk be that PH will appear again?
Yes, but you get another 20, 30 years.
Okay.
And then another pig will die to save you in 20, 30 years.
And when you're 60 plus, like me, 20, 30 years, that sounds very good. Bulgaria, why patients with left-sided heart failure and PH are more stable than patients with PAH?
So there is a couple of reasons for it. And the most important reason is the heart is a very, very flexible organ, and a lot less flimsy, I say, and sophisticated in a way than the lungs. And so when the heart fails, which causes pulmonary hypertension in patients with left-sided disease, people can last with heart failure for a very long time. Also, when the pulmonary vasculature starts getting affected, so you basically have double disease, you have a PVR disease and a heart failure disease. In that case, the lungs are not trying to kill you, are not trying to hurt you. They're just reacting to the heart backing into them. Neither of these scenarios are as bad as the scenario where the lungs spontaneously decide to hurt you. So when you have a PAH disease, a lot of times it's the lung itself that initiates the disease, and apparently it's more committed to make things go bad. But in pulmonary hypertension from the heart, it's either secondary, and heart is very good at continuing for a very long time. And if there is a pulmonary vascular component, it is also secondary. And that means that as soon as, for instance, you have a good day, the lungs start to heal, as evidenced by the fact that actually if patients with left-sided heart disease, they get an LVAD, a left ventricular assist device, not only their pulmonary hypertension from heart failure gets better, but if they have pulmonary hypertension in the lungs, PVR, that also gets better after 3 months to a great degree.
Another question from Bulgaria. Do you think that IV therapy is compulsory for functional class 3 and 4?
No, I have patients who are 80 years old or 90 years old, and their quality of life is more important to them than living. So it's not compulsory if you are okay with having less effective medication in that subgroup. Depends on what you mean by the word compulsory. If you are 30 years old and you have bad pulmonary hypertension in stage 3 and 4, I don't actually really ask your opinion. I tell you that's what you need to do. So yes, it's compulsory in my group. I will convince you that that's what you need to do. But if you're 85 years old and suddenly are in functional class 3, I may give it to you as an option, and then you can pick. Do you want to maybe live a little longer? Who knows? But have to deal with a pump? Or do you want to take a pill and maybe it's not as strong or as effective, but it does a lot and you maybe get a better quality of life. So it's your choice.
Another question from Bulgaria. What are the benefits from the application of gene therapies, and can we speak about customized medicine related to PAH?
Yeah, it's too soon to talk about that. The problem is there is not one gene responsible. We have found a couple of genes that are responsible in pulmonary hypertension. But again, there's a whole slew of them, and I refer you to the presentation in terms of the breadth of those genes. And every day you find new ones in pulmonary hypertension, but we don't have one gene, one disease phenomena. And that's a problem because you have to find out which gene is the one responsible in the patient, and then which genes are the ones that you're going to target. And in some patients, it will be a multiple different kinds of genes that are responsible. So really, gene therapy is in its infancy. And one of the reasons why it has not advanced as much as we hoped it would is because in every disease, there's one or two conditions that basically are derived with one or two genes that derive a certain population to disease, but in most it may be a combination of gene mutations that results in the disease. And so we already barely know how to do one of them, and we have not been smart enough to sort of figure out how to deal with this. And so it's a very, very difficult subject, and it's not ready for I think the artificial lung may come before gene therapy, which is kind of sad, but that shows the limitations. And actually, conversely, it shows the amazing feat of our development, where basically the same spices are used to make different kinds of food, and at different times your genes do different things. And it's amazing that actually we end up as functional as we are. But also this will fundamentally make it hard for gene therapy to succeed.
But then again, don't we have emerging drugs, like you talked about in your presentation, that influence gene mutation problems? So, for instance, this BMPR2, we have drugs coming up that can help if you have this problem and so on.
Correct. And so that's where the other side of this call comes, and where essentially these gene therapies are trying to target the most common genes that are affected. But again, these mutations don't necessarily create pulmonary hypertension by themselves. You have to have, for instance, like a 2 or 3 hit phenomena. So yes, the genetic understanding of pulmonary hypertension is helpful, and we should continue down this path. But I was just pointing out to you why this has not yet necessarily bore fruit yet, is because there's a lot of things that have to happen yet for this to really happen correctly.
Okay. Slovakia, what are the initial combo multi-therapy options in US? Are they paid by patients' health insurance? Is it automatically triple combo therapy?
No. We have had less of a problem with dual therapy. And in the United States, it's very strange. Sometimes the insurance companies, you can do things and they don't notice, and they'll just pay for it. And other times, when you start doing something often enough and it starts showing up in their pocketbook, then they start researching it, and then they go, hey, show me the evidence that initial combo therapy works in a large randomized trial, which then we don't have. So I suspect that one of our problems, if we want to advocate initial triple therapy and induction therapy, which is a version of triple combo therapy, that we would hit a snag in the United States, and probably even more in Europe, that is even more data driven.
Yeah, no, in Norway, of course, we have universal healthcare, so we have no insurance company to deal with.
Correct. But then you have the biggest insurance company to deal with, which is the government, and they are not, they have a lot of bureaucracy and a lot of resources, and a great ability to say no to a lot of things.
Yeah, but not to PH patients and the medication. I never heard about any people being rejected any drug. So
that's wonderful.
If
we
the
see
doctor...
it all the time in the United States, but that's because they trust the centers to do the right thing, and probably the centers do the right thing. In the United States, you have a large number of physicians that write a whole lot of inappropriate medication, which may be one of the reasons why the insurance companies are a lot less trusting of the US prescription writers.
Yeah, like Norway and I guess also other countries in Europe, we're much smaller. So we have 5.5 million people here, and we have one big pH center, and everything is channelized through there. So it's much easier to control.
And Skara, I know you're embarrassed by it, but Norway has the largest sovereign fund in the world. So you guys are per capita even richer than people from Saudi Arabia. So that could be one.
Yes. And you're wrong. I'm not embarrassed by it. Finland has a question. Why is it lung transplant, not heart transplant, to cure pH? I don't know if you
that's a good question. So the problem with the heart. So you ask a very good question. What causes the disease, and this is why I hate the word pulmonary hypertension. I think we should name it pulmonary vascular restriction, because then it makes things a lot easier, and you don't mix up people that don't have to do anything with each other. There are a lot of people that have pulmonary hypertension from their heart, and they need to get their heart replaced. But a lot of you people watching this, and probably people involved in pulmonary hypertension, are people with pulmonary vascular restriction, or essentially what is PAH. Although now other fields, as was in my presentation, the lines are blurring. And so the primary disease is the restriction or tightening of the pulmonary vasculature, and then as a result, the heart fails. As we said earlier, the heart happens to be a very, very resilient organ. And so if you take away the burden of the heart to have to push through that very, very tight lung, a lot of times it recovers. So once you take away the burden, meaning now the pulmonary vascular restriction has gone away, and the new lung do not pose an obstacle to the heart, to the right side of the heart, which is not that strong to beat, then things get better. You may need heart and lung when the heart is so far gone as a result of its codependence with the lungs that it would be the judgment of the transplant center that the heart is not likely to recover easily, effectively, or with a good chance, and then you get both. You get heart and lung transplant.
And for instance, like an Eisenmenger patient with a damaged heart, do they transplant the lungs and fix the heart, or?
So that would be, for instance, a group that may actually get heart-lung.
Another question from Finland: is treprostinil taken orally as good as subcutaneously?
Define good. It's easier to take, much easier. And I think if you take it correctly, and if you don't have as many adverse events, and if you get to the high levels, it is. The problem with orals is a lot of times people are not taking it at doses that they should be taking it. For instance, Orenitram basically starts working at 3 milligram TID. It really starts doing good at 5 and really does its best work after 7 TID. Now, the majority of people are not on that high of a dose. But then you look at sub-Q, and it's much easier for everybody to accept to go on higher doses, or naturally, people have learned to go to higher doses, both physicians and patients. And so it ends up that patient with sub-Q or IV do better than oral, but not necessarily because it's better, but because you get to higher doses. Now, again, one of the problems with oral is people forget. Because of gut edema, the absorption sometimes changes. So PO meds are never as dependable, reliable, and their pharmacokinetics is never as uniform, solid, and good as IV or sub-Q. But I can foresee a world where you would get induced with IV drugs and maybe 2 other drugs. And then afterwards, you would switch your IV to, for instance, oral treprostinil. And I think that would work. So theoretically it is, but practically it's not. And for those 2 reasons. One, it is a little bit more variable. People forget them more often. And 2, they don't get to as high of a dose, either because they're not just used to pushing their patients, or patients are not used to pushing themselves, or the side effects detract them in the middle. But in my experience, if you push, you can get to high doses, and then I think they're pretty good.
Spain, is gene therapy close to be a reality?
No.
Short answer. I've heard some people talk about that gene therapy. One of the reasons it takes time is that there is not too much money for pharmaceutical companies in this.
No. No.
Yeah.
Because have you heard gene therapy work in anything else? We're not behind.
Yeah.
It just doesn't work. It's really hard to crack that code. It's just really hard for the reasons we already mentioned. Usually it's not one gene. Even if it is the one gene, we still haven't figured out how to do it right. Now, the CRISPR technology shows a lot of promise. And I'm sure a subgroup of pulmonary hypertension patients whose disease is driven by one gene, if they find a way to fix that one gene, they may get better. But it's not going to be, oh my God, gene therapy's here and everybody's going to get better because we finally cracked the code. We have not cracked anything, because multiple genes, even with the genes, it's not clear if you fix one, it's going to work. It's just too complicated. We're just not smart enough.
Okay. Is Yulong a temporary solution for the most urgent cases, or is it permanent? Does it have the same viability as a normal lung transplant?
That's what they're aiming for. They're actually aiming for better than a normal lung transplant. One of the problems with lung transplant is, and the shame of pulmonology is, our transplant is one of the worst transplants there is. Heart transplant, my father had a heart transplant. He lived 20 years and died of colon cancer. Even intestinal transplant is getting better and better. But again, people don't give lungs credit. Lung is a very fragile, sophisticated, and refined organ. It's very hard to replicate it and mess with it. But if you're going to mess with it, taking your own cells and using a functioning lung to replicate a non-immunogenic lung is probably the way to go. And no, I think they're thinking about it as a permanent solution, in the sense that, yeah, it may go bad in 5 years, but you get another one.
Yeah, that's terrific. Spain, I would like to know the opinion of you professionals about the sensations and responses of the sotatercept medication trials. We have been told that it will be one of the most important medications we have for pulmonary hypertension. Is it true that according to phase 2 clinical trials, it has been shown to reduce pulmonary pressure and pulmonary resistance by up to 50%? Could a chronification of the disease begin to be assessed with this medication?
Yeah, so we did address this to a certain degree, possibly, but remember, Flolan does the same thing. So it's not like suddenly we ran into something that is so amazingly different. Flolan changes the course of the disease. Flolan changes everything. So yes, it's exciting. And there's a whole bunch of them, not just sotatercept. There's other ones that also are coming out that are getting into the really inside of the cells a little deeper and affecting things that are a little perhaps higher order, which then could have more of a downstream effect. So I'm excited about it. But this is not the first time we've had good medications. So I'm excited about it, for sure.
Yeah, and I think it's important, like you say, that this is not the only drug. There are also many others that are coming up, which can be very interesting to us patients.
Absolutely.
Hungary, we have kept hearing that IV sub-Q prostanoids proved to be the most effective in a combination therapy. Is the oral version of these drugs used in the US? What are the experiences? I guess we covered this partly before.
Yeah, I mean, for instance, one of the things I started doing this, which is interesting, is I bring the patients in, I start them on IV therapy in the hospital, we get them to very high levels of IV, and then we switch them to very high levels of oral. So essentially, within 10 days, you get to go home with extremely high levels of oral therapy, or Orenitram, specifically, oral treprostinil. And my experience with that has been very good. Now, you have to pick the right patient population. So we usually get the patients that are stable, that are doing well, and then we switch them from either bringing them in and inducing them from putting them on IV and then switching to oral. And then they do really fine with oral. Or the patients that have been doing well on IV therapy for 2 or 3 years, for more than 3 years, for a while, and the right heart cath shows that they basically have stabilized in their disease. It has been my experience that if you switch them to high enough of an oral therapy, they can maintain that effect. I do not expect the oral therapy to reverse things that have gone far enough. Remember, we just talked about this. It's not as good for advanced stage 3 or 4 patients in terms of its strength and its efficacy right off the bat. I had a person who come in whose heart was not good, whose lungs were not good. He was on IV and he said, "Put me on oral." And I said, "No." Then she went somewhere else and somebody else put her on oral. And, she started kind of drifting backwards. And I was going to bring her in, do a right heart cath and start her on IV again. But unfortunately, when she came, she coded and died. So, you have to pick those patients correctly. Either earlier patients who you're using prostacyclin earlier in patients who are not as sick, or in patients who are stable and you are trying to switch them from, and they've been doing well and you're trying to switch them to a more convenient mode. Nobody thinks that this is the right medication for advanced 3, functional class 3 and functional class 4 patients, or another way of looking at it, a more sophisticated way of looking at it, patients who are at high risk by some risk score. Pick whichever one you want.
Hungary, earlier we heard about the NO treatment. Is it used in the US? If yes, together with which drugs?
It's used in the intensive care unit. We know it works. The problem is it is so difficult to deliver it that the companies that have been inheriting the device have not managed to get it to really work. Now we're excited. The newest version of it seems to be very promising. So we know it works. We just have to find a way to deliver it. And, more advanced or sicker patients are being targeted. Makes sense, because why would you suddenly start wearing something with a nasal cannula if you don't even have to be on oxygen? So I think we're going to get there.
Long question, Croatia. When you mentioned taking the right therapy, I wonder how you influence on taking therapy regularly, or do you have cases where patients do not take regularly prescribed therapies? We recently had one patient die. His family, after his demise, or is that what you call it, returned a larger amount of medication. We already know how expensive drugs are, to the association, because they were embarrassed to return to the hospital. I fear that the frivolous understanding of this disease and taking therapies led to the death of the young man. I am afraid that there are more such cases, especially among male patients. How to influence more strongly than this does not happen.
Yeah. Well, if you listen to my presentation also, I did mention that we focus on the drugs, but a very important part of our approach for ourselves and for our patients should be disease management. So for that purpose, I just hired a lovely nurse practitioner who gets to see patients in the morning and pay for herself. And her job is in the afternoon, not to make me wealthier or the Cleveland Clinic, but just to call patients and remind them, cajole them, harass them, mother them, baby them, threaten them, any number of these things, so that we can overcome some of our negative parts of our humanness, which then results in things like this. So I'm fully cognizant. I really do believe that there's a lot we can do. Yeah, I mean, taking the medication that you are prescribed that's just as good as adding one to one you're not taking.
Another long question. In the past 8 months, they've replaced my Ventavis therapy with Selexipag. I feel much better now. I don't have oscillations like during inhalation therapy, and my results are good. But the initial side effects were barely enduring leg pain, to the point I couldn't stand for 5 minutes at a time. Now it's okay, but still I sometimes feel uncomfortable enduring pain in my leg. Is this a common side effect in most of your patients on Selexipag? And he's a 47-year-old, and he was diagnosed with idiopathic in age 7, I guess. 71.
Yeah.
Yeah.
So with Selexipag, you know when it works, when it's hurting. So you want to be hurting with Selexipag. If you are not hurting with your Selexipag, you are on too low of a dose. By the way, I think that's why we failed in the Triton trial, because in the initial trials of Selexipag, we pushed the drug until patients were basically saying, no, that's enough. And then we backed up until they said, okay, I can barely tolerate this. And then with time, they got used to it and the results were good. So not only it's common, you want that. And I think with time, you're going to get used to it. If it's really uncomfortable to the point where you can't stand it after 3-4 months, you may go down by a notch to a slightly lower dose, and you probably will get the same effect. But not only pain is not bad in early titration of Selexipag, that's how you know it works.
So it's like in a sports world, no pain, no gain?
In this particular case, yes.
Yeah. Okay, I see we have 13 minutes left and we still have a lot of questions. So Slovenia, in addition to the BMPR gene, are there other associated with PHS? And your answer
yes, yeah, exactly. There's hundreds of them, ALK1, others. But, you know, it just adds to the mess.
Yeah. Slovenia again, is multi-threaded therapy still not recommended for first and second class?
Okay, I'm going to translate that into is multi-drug therapy, meaning 2 or 3 drugs, not recommended for functional class 1 and 2. That's not true. No. We're actually beginning to suggest that you should at least be on 2 drugs, regardless, except if you've been on 1 drug for the last 20 years and you're still alive and doing well, then, you know, that drug probably really works well for you, and it's probably okay to be on that 1 drug. But everybody else, you just showed up or you've been on 1 drug for a year or 2, I suggest everybody would be on 2 drugs, even functional class 1 patients. We have multiple data that even functional class, even functional class 2 patients get worse. So then maybe I don't know what first and second class is.
I think it's what you said, functional class 1 and 2.
But theoretically, there is supposed to be no therapy for anybody who's functional class 1, meaning you have hardly any symptoms. So let's say a low 2, yes.
But couldn't you have elevated pressure and still be in functional class 1?
You could, but we have none of our trials have been done in those patients. And although it makes sense that that patient eventually will develop pulmonary hypertension, and there's evidence that they would, at least in the US, we can't get anybody to prescribe the drug, because if you don't have those numbers and you're functional class 1, then, you know, theoretically, we have never entered functional class 1 patients into trials, ever.
Okay. Do you notice that PH is diagnosed faster than in the past? I mean, I guess
Yes.
they mean earlier.
Yes.
Yeah.
For one thing, in the US, the echocardiographers have now assigned a location where they routinely call the existence of pulmonary hypertension. And this raises the curiosity of other doctors to work this up. Whereas before, they didn't do that, and people would sort of get lost in primary care or cardiology offices.
Can selling patent for 3D print of lungs, once everything is tested, be expected in poorer countries? Boston has agreement.
Yeah, we sort of asked this question before. I hope so. And I hope that some of this would be donated. This is a little harder to donate because there's a lot of technology involved, but probably not impossible. Like I said, there is evidence of governments and national organizations donating money, with the pharma companies also essentially donating patents to make access easier, since they seem to be rich enough selling to the richer countries. So there are solutions for this, but this is going to be a little harder because there's a lot of technology involved. This is not just a pill.
Belarus, do all PH patients in the US receive expensive therapy for free? Or does it depend on what insurance company they have, whether they have a disability?
Yeah, so no, they don't receive it for free. If you are over 65, the government will pay for 80% of the drug, whatever the price is, but then you get stuck with 20%. But since nobody can pay the 20%, there are charitable organizations that basically help you pay for that 20%. But I've had patients that had to come off drug because they couldn't find a charity to pay for it. These charities, incidentally, are also supported by pharma companies. And it actually, yeah, so it's a complicated arrangement. Before the age of 65, insurance companies tend to bear the majority of the cost, and whatever they can't bear, the pharma companies just basically are allowed to forego or donate or help. And so that's what they do. So below 65, the pharma companies help for the 20%. Above 65, charitable organization help. But they don't get it for free. There's actually a lot of legwork, a lot of hassle for me. I have probably like one person 24 hours a day whose job is only doing paperwork to get through this maze so that the patients could get their drug.
This Obamacare, did that help any, or?
No, it doesn't get around. Obamacare is a better way, is a simple government plan. Sometimes it comes out of, Obamacare is not one insurance product. It's basically a concept. And the concept is certain insurances will give you a simple product that's subsidized by the government and cheaper. Or the state will extend Medicaid, which is the insurance for the poor, to more people than just the poor. So then you basically fall under the same problems that I just mentioned.
Okay, we have 7 minutes left and 7 questions, so we need to be under 1 minute per question. What drugs are currently approved for children?
So, well, there's nothing that's really approved for children per se. And so we extend the drugs and we use them. Sildenafil, for instance, was used for a while and then it was found to have problems, but we still are using it more or less. Certainly, a lot of us are using drugs for children after the age of 14, essentially calling them mini adults, even though studies were not done. And I have to tell you, I don't have much experience with children. I never treated a child. So bad person to ask.
Okay. Is mono or dual therapy used more frequently in children?
You not a children expert. Yeah, I'm sorry, I can't answer that question.
Yeah. We have a child, we had a person here talking about PH and children. I wonder if I mixed up the questions and I gave them to you. patients with Eisenmenger syndrome prescribed selexipag?
Yeah, I mean, it depends what kind of Eisen. The problem with Eisenmenger syndrome is there is the corrected and the uncorrected. People with high post pressure and people with low wedge pressure, essentially. So I think some people do in certain occasions and other people don't. So it's complicated. Eisenmenger is complicated.
How often is oxygen support given to patients with PH, and in what case? Is it believed that for some types of heart congenital defects, it is ineffective?
Well, it's ineffective in a sense that the problem is the mixing of blood, and it doesn't matter how much oxygen you give, the blood is still black. However, if we know that hypoxia, low oxygen level, increases pulmonary vascular restriction. And as we discussed, pulmonary hypertension, at least the one we are talking about, PAH, or group 3 or group 4, a lot of these are basically diseases of pulmonary vascular restriction. And in a sense that they're diseases of pulmonary vascular restriction, hypoxia is a bad thing. So the better your oxygen number, the more open your lungs get. Does that mean that you should be at 98? No. We actually don't know exactly what you should be. We think you definitely should not be below 90 because we extrapolated from COPD patients that anybody who goes that low will have a lower life expectancy. But actually, there are very, very little, if no data on really do people live longer because they have better oxygen, surprisingly, in patients with heart disease. And does it matter if your numbers go down when you're exercising? But turns out in COPD, we have not found it to do anything. It doesn't shorten your life if your numbers go down. It doesn't help anything, except sometimes people feel better. So we still give it, but a large randomized controlled trial showed that low oxygen with exercise doesn't matter. Now, low oxygen at rest and low oxygen during sleep does matter. So then we asked the question in COPD, if low oxygen is bad, does middle oxygen make you better? And the answer was no. So extrapolating that, because we don't have data on pulmonary hypertension, we know that low oxygen is bad. We're not sure if high oxygen or intermediary oxygen is good. We know that feeling good is good. So if more oxygen makes you feel better, do it, I guess. And if you're low, you should definitely do it. And everywhere else, I'm not sure whether you should do it or not. And it's true that patients with mixed disease, with congenital, it doesn't work as well.
Has inhaled treprostinil been available in the EU since 2004? I don't know if you know anything about this.
I don't think inhaled treprostinil is available in EU, but maybe it is. But again, I'm here to talk more about science and how things are done in the US. Unfortunately, my knowledge is limited. But I don't believe it's.
Is there any substitute for treprostinil IV being studied in the clinical trials?
Yes. I believe, for instance, countries like Germany actually use iloprost IV with great results. And I'm not saying that this category, they're all interchangeable because they're all slightly different. But for instance, Velletri or a room-stable Flolan are different formulation of ipraprostanol. So there's now different formulations available. IV treprostinil, IV iloprost, room-stable Flolan, Velletri, and they're all substitutes for ipraprostanol.
Last question. Medical devices for this therapy are too old and uncomfortable for the patients. Are there any devices being studied that could replace those currently used? I guess it's refer back to the other one.
Maybe, but I think maybe you're talking about the pumps, if you mean by devices. Well, yeah, I mean, United Therapeutics just came up with Remunity, which is a pump that's about that big, and you can give medication through that pump. So yeah, the advances are coming.
Well, We have 1 minute left to wrap up, and once again, I have to say it's been really a pleasure to have you. You also talked to us last year, and you had a very, very interesting presentation. People loved it, and thank you so much for your question and answers. Enjoy Florida, and we hope you'll speak soon again.
Thank you, and I wish all of you, SCARA and PHAE Europe, all the best success.
Thank you.
Okay.
And for all the audience, we now have to leave this and go into the next room where Preston will be. Thank you.